Thank you, David. It is such a pleasure to be here today for this event. I'm going to be talking about what shapes health, and mainly sharing with you a few highlights from a booklet that was distributed as you came in. Additional copies are available, and it will be up on it's on actually the Foundation's website as of this morning. It's called Overcoming Obstacles to Health. This was co-authored with my colleague Susan Egerter and represents a review of current knowledge of what it is that shapes health. I want to underscore one of the main conclusions from in Overcoming Obstacles, and that conclusion is that although there is a lot that we do not know, we do know enough now to act. There's a tremendous body of evidence, of knowledge that has accumulated that can guide policy. So now let's see if I can manipulate. There we go. Okay. So first, I want to pose a question to you. How can it be that we spend more on medical care than any other nation on the face of the earth, and yet we rank at or below other industrialized countries on multiple health indicators? Now, for some of you are probably thinking, well, this isn't really news. I mean, we have known for quite a while about the U.S. ranking very low on infant mortality and life expectancy. But the unfortunate news that's there came out in a report from the National Academies of Science in January. And in that report, the U.S. health disadvantage was documented across more than 100 indicators, so it was most of the indicators that were looked at, and at all ages up to age 75. And it's not, this U.S. health disadvantage was not confined to the poor. The health disadvantage shows up even when we look solely at affluent people, comparing affluent people in the U.S. with their counterparts in other countries. Now, let's look for some clues to the answer to that question of how this can be that we have such poor health despite spending so much on medical care. So the residents of the DC area will recognize very well this schematic rendition of the metro map in the DC area. And what it shows is that there are dramatic differences in life expectancy for people who live just a few miles away from each other. So for example, a baby born in Montgomery County, Maryland, or in Arlington, Virginia, is likely to live 6 to 7 years longer than a baby born in the district proper. The differences can be much more dramatic even than this, and as you'll see inside your copy of Overcoming Obstacles to Health, the difference that's there in a city like New Orleans is of 25 years, a 25-year difference in life expectancy. Now, here's another clue, I think. How long we live correlates very strongly with our income and with education. So this slide shows you life expectancy at age 25, and I want to emphasize that it's at age 25, not at birth. That life expectancy at age 25 varies by educational attainment. And in this slide and a couple more that I'm going to show you right after this, as you go from left to right, your left to your right, education or income in the subsequent slides actually rises. And you can see here that 25-year-olds who haven't completed high school, represented by the bars on the far left for men and for women, even those who, I'm sorry, that 25-year-olds who haven't completed high school are likely to live 8 to 9 years less than 25-year-old college graduates. But it's not just a matter of the extremes. If you look at the bar that reflects people who have gone to college but not graduated from college, comparing them to the college graduates, there too you see a substantial difference. It's a difference of 2 to 4 years of life expectancy. And I think this is a very important clue in seeking an answer to the question. I want to point out that the patterns seen on this slide and on the next 2 slides that I'll show you, the patterns were essentially the same whether we looked at education or whether we looked at income. So this slide shows how children's health varies with their parents' income. So as income rises from poverty level, which is on the far left, to 4 times the poverty level or more on the far right, the percentage of children whose health is not excellent or very good falls. In other words, more income, healthier kids. As in the last slide, you see the largest difference between the most and the least advantage. So children of poor parents are over 4 times as likely as children of the most affluent parents examined here. They are more than 4 times as likely to have less than excellent or very good health. But here, too, you also see a substantial difference between children in middle-income families, represented by the bar that's just next to the far right bar. That we found very similar patterns with health improving increasingly as income or education rises when looking at scores of different health indicators. These gradient patterns, I mean this pattern of incremental improvement with higher education, with more income, these gradient patterns, along with the literature using a whole range of techniques to reduce bias, we believe that these gradients add to the evidence that the pervasive links that we see between health on the one hand and income and education on the other, that these actually reflect the fact that income and education have powerful effects on health. So reflecting the tragic and shameful and long legacy of racial discrimination in this country, this slide illustrates that Blacks and Latinos have lower levels of income and lower levels of education. This one is on education. The pattern is the same with income. So some people may assume when they see the patterns that I just showed you of health varying by income or by education, some people may assume, oh, this reflects underlying racial or ethnic differences. But a lot of evidence, including this, tells you that this is not. So here what you see is within each of the major racial ethnic groups, you can see striking differences in health according to education. And these gradient patterns, again, we have found apply to most health indicators. So health differences by income and education cannot be explained by racial or ethnic differences. Now, the scientists among you may now be thinking of the question, but is it plausible, according to the latest in biological science and according to the latest in social science, is it biologically plausible that income and education shape health? This slide shows different pathways from education to health, all of which are supported by evidence. I'm not claiming here that there is total consensus on every link that's depicted here among all researchers, but I am saying that there is a critical mass of evidence from a critical mass of prominent scientists that supports the relationships shown here. So the most established pathway is that at the top, the one that goes from education to greater knowledge and greater skills, and there to better health-related behaviors, and then to health. And that's the pathway for which we have the most evidence. There's a massive amount of evidence for that pathway. But the scientific literature also tells us that the other 2 groups of pathways are likely to be important as well. So for example, the middle cluster of pathways shown in the slide shows how more schooling leads to better paying jobs. That should be rather intuitively obvious, and there's plenty of data on that. But then in turn, with higher paying job, there's a higher income for the family, that makes it easier to purchase a healthy diet. It makes it easier to pursue leisure exercise. It makes it easier for people to rent or buy a home that's free of lead or mold and other hazards, in neighborhoods with safe places to play and exercise, and with better schools. So more income also can mean less stress by giving people the resources to face everyday challenges with less strain. So all of the pathways shown on this slide are likely to operate to connect education with health. So you can see, just from looking at that, you can see it's not simple at all. Both education and income affect health through very long and complex causal pathways. The health effects of education and income may not appear for decades, particularly when we're talking about the causes that lead to chronic disease. They don't develop overnight. You have to be following for decades. So we cannot assess the effectiveness of interventions with social factors like income and education by looking for results in just months or even a few years. We have to rely on intermediate measures. And because the results of an intervention may vary with many different factors, interventions need to be tested in multiple settings. There we are. So I've mentioned stress, that more income can buy you less stress because you have more resources to cope with everyday challenges. How does stress get under the skin? During the last 10 to 20 years, there has been an explosion of knowledge in neuroscience identifying physiologic pathways involved in stress. These pathways begin in the brain, as depicted in this slide, and they set in motion series of events that ultimately affect many different organs and systems. We have learned that chronic stress, for example, that due to long-term poverty or family trauma in childhood, can lead to heart disease, to diabetes, and premature mortality in adulthood. Racial or ethnic differences in health may be explained in large part by the large differences in income, wealth, and education that are the legacy of racial discrimination. But in addition, many experts, and I can't resist pointing out that David Williams is a leading scholar in this field, many experts believe that racial or ethnic differences in health may also be explained by the added burden of stress experienced by Blacks and Latinos related to racial bias, even in the absence of dramatic incidents or even in the absence of anyone intentionally wanting to discriminate. So stress, particularly prolonged stress, can harm health at any stage of life, but the effects of chronic stress seem to be the deepest and the longest lasting when they occur in childhood. Stress due to chronic poverty, for example, can actually disrupt a child's physiologic systems in ways that alter brain function and immune defenses, leading to inflammation and chronic disease. These changes may become permanent, and some of them may even be passed along, transmitted across generations. So let's revisit. I'd like to revisit the question that I posed at the beginning. How can it be that we spend more than anybody else on medical care, and yet we rank at the bottom of the heap on most measures of health? Could it be that we're doing poorly because we have focused too narrowly? We have focused on medical care and on what individuals can do to improve their own behaviors. We have failed to address sufficiently the conditions that constrain or enable people not only to get medical care, but also to adopt and to maintain healthy behaviors. And we've failed to consider the factors, particularly stress, that can directly affect health, even without involving either medical care or behaviors. To have a healthier nation, we need to consider the policies that shape income and education, which we have to see as basic resources and opportunities for health. Policies that affect education, income, childcare, nutrition, housing, and neighborhood conditions are health policies. But too many people, including the middle class, face obstacles to health that only society can overcome. Individual responsibility is very, very important. So there's much to be learned, but we know enough now to identify the most promising approaches and to test them rigorously in different settings. The panelists today will speak to what is currently known about approaches that seek to improve health by broadening the focus, looking beyond medical care to the social factors that shape how and where we live, learn, work, and play, that in the end are the most powerful determinants of who gets sick in the first place. Thank you.